कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you, Arun. Priscilla?
Yes, ma'am.
Yes, please carry on.
We move with the first talk for the session today. The chairperson for the first session is Dr. Prashant Adiga. Arun, can you please put up the slide of Prashant, sir? We welcome you, Dr. Prashant. Prashant is a professor and head of department at KSOGA. Bestowed with various awards. He's also done his fellowship in reproductive medicine, and he has been a speaker at various international and national seminars, and also contributed chapters to various textbooks. We welcome you for the Endoscopy Committee KSOGA webinar, sir. Over to you, Prashant, sir.
Thank you. Now, it is my privilege to introduce the speaker for the first talk, Dr. Bharadwaj. Looking at his CV, one thing is for sure, he is a very academic person. Also, I think minimally invasive surgery is very close to his heart. And he has received a lot of awards, Youth Icon Award, and the National Conference Award, Jeevan Rakshak Award, many awards. And also, by looking at his contribution towards chapters and publications, I'm sure he is research-oriented also. And his passion, I presume, or I think, is robotic surgery, and of course, minimally invasive surgery. With these few words, I introduce you, Dr. Farendra Bharadwaj. Over to you, sir. Over to you, sir.
Thank you, sir. Thank you, Prashant, sir, for your kind words. And I hope I'm audible.
Yeah, you are audible, sir.
So let me start my presentation. I'm just sharing this thing. So at the outset, I would like to thank Prabha Desai madam and the whole society for giving me this opportunity, and a very good collection. And I can see everybody is appreciating Prabha madam for conducting such good webinar. Thank you so much, madam, for including me in your list. So nice of you. So the task what is given to me is to introduce something very basic of hysteroscopy. So, actually in the hysteroscopy, the important thing is there are two very important things which everybody should understand. One is keeping the orientation into the cavity. That means you are in the cavity, that one should know. You are in which part of the cavity. The both ostia should lie on the side of each other. And even if the ostia is looking ups and down, the surgeon should know that, yes, I have rotated the camera. Another is to maintain the clear vision into the cavity, which is the principle of the irrigation. So the cavity, we need to continuously irrigate. It is the difference of inflow and outflow, which gives you distinction. And because of this inflow and outflow, you keep on irrigating the cavity, the mucus and the blood. And this is how you keep the cavity clear. So guys, these are the two very, 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 very important things in hysteroscopy: maintaining a distinction and maintaining an orientation, and one can perform a good surgery. Now, if I'll show you this video, I hope all of you can appreciate that there is some fibrosis. Don't know which part of the cavity you are. Fine. This you can understand. The surgeon is trying to move into the cavity of cervical canal and then trying to negotiate into the internal os, where he is facing some adhesions and fibrosis. He's trying to negotiate. He has seen some black hole there, and then he has entered into the cavity. So guys, just I wanted to stop you here that if all of you can appreciate whatever I was speaking, that's an art in hysteroscopy. So the moment you are entering into the canal, you're using your vision, you're using your pressure in such a way that you are able to appreciate whatever I was telling, that these are the rigors, crabs, internal loss fibrosis, etc., etc., etc. How one can do this thing? By understanding the equipment and instrument and the optics of the hysteroscopy. Then when you enter into the cavity, you orient yourself that this is the posterior wall, this is internal loss, this is the panoramic view of a cavity, this is a right lateral wall. You should know that this is the right side of the patient because you're sitting between the legs. This is the left wall, this is the anterior wall, fundus, etc. And you have seen that there are some fibrosis on the left wall because we have not dilated this cavity. We have entered into the cavity straight away. So this is how you can document the finding of the intrauterine cavity. And when you are reducing the pressure, there were hardly any fibroid which you can, the polyp which you can see. But by reducing the pressure, all of us can appreciate that there is one sessile polyp lying in the anterior wall, which was not visible at that time. So guys, the crux is it is not only the intrauterine surgery which will help you in doing hysteroscopy. It is your pre-op imaging which has a tremendous role in hysteroscopy. So one who's want to excel in the field of hysteroscopy should have a decent and at least basic knowledge of ultrasound and transvaginal as well, because it is preoperative diagnosis and then intraoperative execution and treatment. Yes, we say this, Prabha madam, this terminology we use that this is see and treat. But there are something which you cannot see even in hysteroscopy, like type 3 myomas. You cannot see on hysteroscopy. So for that, the person should know on ultrasound, the mapping of fibroid that yes, that type 3 fibroid is 2 millimeter or 2 centimeter or 1 centimeter away from the fundus. Then intraoperatively, you can mark these fibroid and you can perform a myomectomy of a type 3 fibroid as well. So guys, this is just a initial statement from my side. Then I'll start. That hysteroscopy previously considered as yes, visualization of uterine cavity, but we call it as visualization of cervix as well, because we are entering directly from the external os. So yes, we are visualizing cervix, cervical pathologies, internal os fibrosis, cervical canal fibrosis, Nabothian cyst, Nabothian calcifications, etc., etc. And one of the entity is isthmocele, which is lying into the area of cervical area sometime. Yes. You may have a Yusuf syndrome as well, which connection is into the cervical canal. Yes. So this is how you can manipulate or increase your spectrum of hysteroscopy. Then visualization of the uterus, which we have already discussed. So now to visualize all these things, the key components are endovision system, the sheaths, the instrument, and the distension median pump. In general, this is what is I meant to say, that camera, you should know how beautiful camera you are using and holding, and you can maintain the orientation, distension media, so that you can keep the cavity clean. These are the 2 points which I'm going to discuss. So it is basically a replacement of your eyes when you're using a camera. So I would say if you're replacing your eyes, please use the best quality possible camera which you can afford, because it is ultimately the way your brain is processing, the same way the camera is processing and giving you picture on the monitor. The way you cannot see in the black light, yes, you cannot see in the cavity because cavity is absolutely bad. Then that means a light source is of a very, very, very important in hysteroscopic surgery. You should use a very good light source and without a breakage of light cable. So your light cable should transmit a good quality of light to your telescope so that this light can go into the cavity and you can see a better vision into the cavity with a good camera system. These are certain components. Probably it's not a domain of mine, but it is a telescope, which in laparoscopy called as a laparoscope, in hysteroscopy called as a hysteroscope. This is the camera head with a chip. The chip converts the optical impulse into the electrical impulse, go to CPU monitor, and this is how the light cable works. Yes, on an average, this is how your OT monitor should look like. You have a monitor, you have a right light source. Please keep a recorder system as well. Please keep a good CPU, light source, and a hysteroscope. And if you your OT is well equipped, you can afford to keep an ultrasound in your operation theater. It's nothing like that in hysteroscopy. This is what commonly office hysteroscopy person are using ultrasound as well in see and treat policies. As I've already discussed, in laparoscopy, somebody else is showing you the camera. The way in Mahabharata, Dhritarashtra was shown by everything by the Sanjay. Whatever Sanjay is telling, Dhritarashtra has to consider that this is the truth and this is the issue. So sometimes it becomes difficult and irritating that please show me on this, please show me on right or left. But in hysteroscopy, you have to behave like Arjuna. You yourself is holding the camera, you yourself is visualizing the target, and you yourself is operating and performing the things. This is, of course, God is there to guide you, which is always there with us. So again, I'm coming back to my key component. Now I'm not going into the details of your camera system, which Ultra HD, 4K, etc., etc. But yes, in hysteroscopy, whatever we are using is a two-dimensional camera, 2D cameras, because depth is hardly 3 to 4 centimeters in which we can work. The moment you are going for 3D cameras or robotic system in hysteroscopy, the diameter increases. So as of now, all of us are working by reducing the size of a camera and the unit to work into the uterine cavity. We have got a bigger system as well to deal with very few bigger size pathologies like bigger myomas. Otherwise, septum, RPOCs, polyp, you can work well with a smaller size. So if I'll talk about the telescope, we have got a 1.9 smaller size one, 2.9 and 4 mm standard one, dimension wise 0 degree and 30 degree are standard. But to use in a resectoscopy, we all recommend to use a 12 degree telescope, which is available with us. Of course, any of you are using HTRS system, hysteroscopic tissue retrieval system, we use 6 degree telescope. Rigid and flexible, both are options are available, but we use rigid for operative work. Flexible one are not good for operative work. They are available for diagnostics. Since I have to cover all these parts, I'm covering. The difference between hysteroscope and laparoscope is that the hysteroscope has a groove. Laparoscope doesn't need to have a groove because it goes straight away into the trocar. But hysteroscope should have a groove so that it can be easily fit onto the sheets of your camera, hysteroscopic sheets. It's a small difference between a 12 degree and 30 degree. 30 degree, as you can see, the angulation is 30 degree. Of course, it can use a wider angle to visualize your difficult area. 12 degree is relatively straight. So we use 12 degree to do a resectoscopic surgeries because there you need to see the loop, which is completely visible when you're operating. You need to see that Teflon should not come into your view. So this is a small technical video just to make you understand that this is a 30 degree telescope. It is written on the telescope that it is 30 degree and 2.9 mm in the diameter. And then when you are going into the canal, you can see this white Teflon, which is visible. And whenever the loop is going away, you may not be able to appreciate that the loop where it is. Though the distance it travels in resectoscope is 2.5 centimeters fixed. So one can understand in his brain that yes, of course, this much I moved. Here I'm showing with the 12 degree telescope, which is with us. So this telescope of 2.9 mm diameter, we use it in resectoscopic surgery where the lower edges are also visible. So whenever you're coming closer to the biomas, you can really take out a good shape and your vision is visible. And even in terminal end, you can visualize the loop completely. Especially it is important when you're doing bipolar resectoscopy. So these are certain difference. And if I talk about sheath, yes, sheath is almost like a trocar in a laparoscopy. You put a trocar into the abdomen to pass the gas. Here you put a sheath into the uterus to push the water. You have another trocar on the side of the abdomen to flush the CO2 from the abdomen wall. You have got an outflow channel into the sheath from which you can irrigate the cavity. It's as simple as this. Yes, of course, many people comes to you and say that this is a diagnostic sheath, you have got operative sheath. No, guys, now we have got only one sheath, which is oval shaped sheath, commonly called as Bitoki sheath or 5 mm sheath, which has got an inflow, outflow, operative channel as well. So just to beware you that, please don't buy all such sheath, which company person saying that, yes, this is a diagnostic one. See, they are single channel sheath. They do not have a channel as well. They are very difficult to maintain the distinction, and these things are available. So various sheets are available, standard, old, multiple channel. I don't want to go into the details. If anybody wants and put a question, I can discuss. But guys, what you need to know that this sheath, this is a 5 mm oval shaped sheath called as multiple channel sheath, or you can say that this is Bitoki sheath, which was designed by Professor Stefano Bitoki. It has got a outer sheath, outer channel, and an inner channel. Outer channel is connected with the outflow. Inner channel has an inflow. Everywhere the inner sheath has an inflow. Outer channel is meant for outflow only, and it has got a inflow channel where the water is coming from this channel, as well as this channel is shared by the instrument channel. So I'll be discussing and offering this sheets only. So if I'll draw it like this, then the vertical diameter is 5 mm and the horizontal diameter is somewhere around 3.3 millimeter. So this is very important. You need to understand that this is elliptical sheet. If you want to go into the cervical canal, which is elliptical one, so you cannot go like this anteroposteriorly. So I insist my students and colleagues and fellows to, move your sheet in oblique dimension whenever you're going into the cervical canal. I'll be showing you, because madam has given me the task of, showing a cervical negotiation as well. So to negotiate the cervical canal, you need to understand this sheet very well. So this is all these things I've discussed. It is 5 mm outer sheet, inner sheet is 4.3 mm. It allows 2.9 mm telescope to be kept inside. It has got a smaller sheet as well, which is called as Bitoki 4 mm sheet, which allow 1.9 mm telescope to insert. Rest everything is same. So because of 1 millimeter reduction in the diameter, it reduces the outer diameter and inner diameter as well. As a small video of the same sheet, you can visualize that this is inflow, which share the instrument channel. Here you put your telescope, and it's look like oval one. So here is a telescope which comes 2.9 or 3 mm, you can say. And instrument channel is very small, which 5 French. 5 French is the area from which the water is coming. So madam, it is very difficult for you to achieve a pressure of 300 mm of Hg with this 5 French. It is very, very, very difficult. So even if your monitor is showing your channel, you don't achieve with this mechanical sheath. This, of course, with resectoscope, you can achieve whatever pressure you want. So this is how, your inflow is pushing the water against the wall of the uterus, and the outer sheath, which is slightly, the perforation are slightly away from the tip, and the ergonomics is like this so that it can easily wash the cavity. So there's a lot of science behind these perforations and how these are made. We have got a bigger size sheets are also available, which are oval shaped sheet, not named as a Bitoki sheet, in which you can use 7 French instrument as well as 9 French instrument. 9 French is almost 3 millimeter instrument, which we are using nowadays in shavers as well.
Yeah.
Bitoki IBS system. So these are sturdy instrument which many of us are using way back as well to perform some intra-uterine surgeries without using energy. So, but your sheets are also available, which can allow you to adjust your 2.9 mm telescope or a 4 mm telescope, whichever you want to use. Resectoscope is another next level sheath, which is used for electrosurgery. So it has got certain component, which are electrodes, gun, and outer flow, etc. I'll be discussing, but if I talk about classical or standard size resectoscopes, 26 French, which is a bigger one. Nowadays, what we are using commonly is 22 French, or we have got a smaller size resectoscope are also available, which are 16 French or 15 French, but Professor Gubini has made them in oval the way the Bitoki has made them in almond shape. So just to accommodate the cervical canal so that they can perform resectoscopy in office as well. So yes, they are also available in the market. So it is the outer sheath, this is inner sheath, this is working element, and this is a telescope which we commonly use, and it has got electrodes, which are various shapes. You can use it according to your need of surgery. So it's just a small video which is showing, how to assemble these things, because I'll be happy to be personally to be there to teach you, all these assemblies and how these equipments and instruments are working, which is very difficult for me to demonstrate you in this webinar. But at least I'm putting some effort so that you can understand. So this is how the fenestrations are different in outer sheath and resectoscope comparative to your fenestration, what you have in your mechanical sheath. And this is The outer sheath which carries both inflow and outflow channel in resectoscope. So I'm talking about resectoscope now, not talking about the mechanical sheath. So yes, you put an inner channel, and which inner channel has got a slot which allow, to adjust in such a way that inflow fits into the inflow. In all the resectoscope has got markings. So where you can insert your inflow and outflow. Compared to your mechanical sheath, we do not have, may not have a marking, but a resectoscope always have a marking for the inflow and outflow channels. And this is how you are loading the gun as well, which is working element. So you take the working element and you insert your electrode very gently. You should not press the, the outer clips of the electrode, otherwise it will lose its freeness of the moment. So very gently, one should insert the electrode into the slot, and later on you can connect the channel, electrical connection. If you are using monopolar, you can attach monopolar. If you are using bipolar electrode resectoscope, you can connect the bipolar resectoscope. Yeah, all these instruments are available. So fine. So this is how we have discussed the cutting loop, ball, button, and angulated knife, which is Collins knife. Collins knife is commonly used for septum, lateral metaplasties, etc. You've got a button which you use for fulguration. You've got a ball which you use for cauterization, and cutting loop which you use for cutting off mainly myomas or otherwise a bigger size polyp as well. Yes. So various other shapes are also available, and one can use. This is how resectoscope. A resectoscope doesn't push the water like this, like a jet. It just pours the water into the cavity. So when you're not pushing it, obviously the fenestration are very close, and I've shown you the fenestration philosophy in resectoscope as well. So now this is all about sheath. Now I'm talking something about instrument. Yes, if you're using mechanical instrument, mechanical sheaths, or in sheath which is 5 French instrument, various shape, the way we have in open surgery and laparoscopic surgery, same in hysteroscopic. Scissor is a very important one. Tenaculum, alligator grasper, and biopsy forceps are commonly used. One can have many other instruments are also available. If I'll talk about the scissor are unidirectional working and bidirectional. In hysteroscopy, we recommend you to use a single action jaw scissor, which is a much more sturdier one, but not to use this very flexible one. We recommend you to use a rigid one, which you can use it. It lasts long. You have got a bidirectional scissors, which are very, very fragile and one can break. Of course, these are available in the industry. You can consider if you want to buy. And it has got a rotating channel, which you can rotate. But it is better to learn rotating your wrist in hysteroscopy rather than rotating your ball or the rotators. So just this is how the grasper are working. You have got a good quality grasper used, because otherwise they can improve. You have to maintain them very nicely, because wash them nicely. Use a silicone gel to keep them lubricated, so that they can work long for you. And so this is what is a rigid and flexible instrument. One can say that flexible one are not, you can not break them easily, but it's not like this. One can use 5 French electrosurgical instruments are also available, which are hook, needle, bugbees, which can be used safely into 5 mm sheets of 5 French channel. And one can use a bipolar current as well, just to coagulate, fulgurate, to remove the septum, and many other things which we are doing in mechanical things. So overall is something brief I can discuss, and I can talk continuously. But ultimately, when you're performing the surgery, that time you should know how to assemble all these instruments. So once you have attached the assembly, then you can see how I am holding the unit into my hand. That's a very balancing way to hold this. And then once you have hold it, you attach the light cable so that the balance is maintained. Then you attach the inflow system. You should always have a channel which are there on the inflow. You should not use just only a rubber valve just to push it. Otherwise, you can break or damage the instrument. Better to use a screw to fit the inflow and outflow. And then lastly, you can attach the camera system. Once everything is attached, do a white balancing. White balancing should be done at a particular distance where the light is completely reflected back. A white light can be reflected back into the camera. Otherwise, one can use a white gauze completely. Now, second thing is focusing. Now, focusing should be done depending upon the focal length. In 3 mm instrument, the focal length is 3 centimeter. 10 mm instrument, the focal length is 10 millimeter, 10 centimeter. So one can do, because these gadgets may not have auto focusing facility. So it's better to focus it beforehand. And then you can perform your entry technique. So this is what I'm just showing you, the how the movements of light cable one can do. One can hand in one instrument, visualize the area. So this is by techniques of going into the posterior fornices and then take the light cable down, seeing the posterior lip of the cervix come out. Once you see the external os, enter into the external os, come into the alignment of the cervical canal and move. Next, equipment has got a HTRS system, which doesn't use electrical current into the cavity. It uses electrical current to rotate the motor, and the motor is actually doing the job for you. So it's a mechanical cutting. So it has got in various companies are available. This is what I'm showing you is IBS system, which has got a 6-degree camera, and it is inbuilt camera, and it has got an operating channel where you can attach the generator or a vibrator on which the instrument is already loaded. It has got a suction which is attached onto the area, and this is a channel for the inflow. So one can attach, and the same company provides you mechanical instrument as well, which are 3 millimeter in diameter. So this is the generator on which you are attaching the instrument. It rotates in this way along with the suction attached on it, so that it sucks the endometrial tissues, polyp tissues, or with using of hard blade, it can suck the myomas tissues as well. And the moment this tissue come in closer to the proximity of the blade, and it cuts them. So it cuts them, simultaneously suck them into the cavity, and you can take it out for the histopathological examination in the same setting. So these are the certain advancement which we have got in our hysteroscopy. Next thing is positioning. In hysteroscopy, we recommend you not to use a head low. It's better to keep the patient in supine in an extended lithotomy position, so that you can work in all direction, because you have got a fulcrum which is working at the level of cervix. At internal os, it's very very odd position if the patient legs are extended. So better to use a very flex leg, so that you can move all around and you can perform your surgery. So positioning and anesthesia should be decided beforehand. This is a video of overall assembly, which I was showing you, how to enter, and this is a correlation of your entry process into the cervical canal. So keeping the light cable down and going into the posterior fornices first, then I'm coming back. When I'm coming back, I can see this posterior rubeus, vaginal rubeus, and a posterior lip of the cervix. So once you are sure that you have seen the posterior lip of the cervix, try to find out the external os. This is how we work in our clinic and OPD. If you want to perform your hysteroscopy, you can see this is the external, which is elliptical. The moment I'm entering near to the external os, I will rotate my light cable in such a way that it will fit into the alignment of the cervix. So once it is fitted into this alignment of the cervix, you can move gradually into the cervical canal. Yes, keeping this cursor, the slot cut end near to the internal os. And then once you have entered into the cavity, it's better to not to jump on the pathology, first to evaluate the cavity, orient yourself that you are in the cavity, or both the osteas are visible, and in relation with both the osteas, for pathology is lying in which wall, interior wall, posterior wall, right lateral wall, left lateral wall, and plan your surgery as per your expertise. This is another video of just showing you the cervical rubeus. So these are cervical rubeus crepes which are there. It looks longitudinal, but in textbook it is described as horizontal, because when a woman is in standing position, they comes in a horizontal view. This is the cursor. The cursor should be kept near to the internal os, and this is how you are entering into the cavity. So these are the anatomical landmark where one should know that if I follow this landmark, I can really go through into the cavity. So here you can visualize one ostia, the other ostia is not visible. So of course, preoperatively ultrasound, you must be having imaging. So you know that this is a triangular shaped uterus, where only one ostia is visible and the other ostia is completely obliterated, obstructed by the adhesions. It's a case of an intrauterine adhesion. And then you can keep on working, keeping yourself oriented into the cavity. Is one ostia is on this side. Now I need to search the other ostia exactly bang opposite to the previous one. So this is how your orientation philosophy work into hysteroscopy. And this is, certain cases where the external loss is not visible. So I recommend and I insist my students as well to evaluate the patient not only by imaging, by clinically as well, that you should have a cervix which is visible, how the external loss is looking like. If it is a fibrous one, torn one, you can consider, different approaches. So in this case, the cervix external loss is not visible at all. No cervix is visible. So it's only a very pinpoint area from where the blood is coming. So we have kept this patient during the day of menses, so that at least we'll have some guide. Otherwise, you can use ultrasound assistance as well. And then by this, last day of menses, this blood is guiding you and you are going into the correct path. So these are the certain strategies which you consider when you're performing surgeries in that very small area and very spacious area, which is very precious as well. So this is all from my side, Prabha ma'am. And thank you so much. This is my team with which I am working regularly in my college, Jaipur and Mahatma Gandhi Medical College. And if anybody wants to come and see and observe with us, and you're welcome. So thank you so much. This is all from my side.
Dr. Bharadwaj, I think next time I will come and surely visit you. I had come to your medical college as examiner.
Ari, sir, thank you so much. Thank you so much.
Yeah.
Please do come again.
Okay, I'll surely come. It was a very interesting talk, and I think Dr. Bharadwaj has, highlighted the important aspects of, whether it is entry or how to tackle these menaces. I know 45 minutes is too short a time, or half an hour is too short a time, but I think given the limited time, I think he has done a wonderful job. I think we are open for questions. Any questions are there, you can always type.
Yes.
I think
I'll be happy to answer if somebody can, if they want to just straight away directly to me,
Yeah.
Can I ask you a question, sir?
Surely, ma'am.
Yeah, basically I put it in the chat box also. The histoscopy scissor, if you have not used your spare scissor for longer time, it got jammed at the tip. And I think it is rusted, tried with the hydrogen peroxide, but it's not. Is there any other thing I can do?
Yes, ma'am. One is first important thing is use a German scissor, German steel rather than this local steel. It can easily get rotten. Second is immediately you are done with your surgery, dry them completely with your hair dryer or put them into the sunlight or whatever it is. Dry them completely. Then put a silicone liquid which is available, or you can use just anti-rust spray which are available. Just put that spray. And then after one day, you can autoclave them ETO them and just keep it in the packet. So see, madam, all of us are doing the same thing every day and night. The moment we are done with the surgery, we dry them, clean them, put it in the sun. If I'm at home, if I'm in the operation theater or where the dryer is available, dry them. And immediately I put either that spray or silicone oil. One can use glycerin as well, but glycerin se thoda sticky ho jata hai. You can use them, and this is how you can use them for years. But buy a German scissor, a good quality steel. That's very, very important. You will get it from the vendor ranging from 12,000 to 50 or 60,000. But practically, company charge you a lot. Otherwise, if you'll ask your vendor, they'll provide you in 12,000 to 18,000 easily. So please negotiate with them.
But now what should I do, sir? Just
nothing.
to release that. Throw it off. Okay.
Throw them. Give it to your students so that they can learn, and otherwise nothing else.
It's not opening only. They
throw them, madam.
Throw it.
Nothing.
Thank you, sir. Thank you.
And the advantage is with the German scissors, we can actually push there is a channel, we can push it and clean it. And the other thing, if you have a medical air, you can also put in medical air so that all the droplets will come out. And especially with the jaws, that is the thing. So you have to keep it on a flat surface, clean it. If you don't have a dryer, or so that is one way we can do. And you can also put a fan at a little higher speed. That's how we can.
Yeah. So some of these Indian scissors are you can detach them completely nicely, and then you can open them. And otherwise, many of them they don't provide you this system of detaching. They are attached, and then it is very difficult to clean them. So whatever scissor you are using, whenever you are buying them, ask the how to clean them properly. They will teach you. They will guide you. Or better to use this German quality scissors.
Thank you.
Yeah, Dr. Farendra, excellent presentation. I'm really happy for your, from basics you are taken, it is very difficult. I know when you are going into robotics and talking on the basics is very contrast thing, but you have made everybody comfortable and understand the thing. See, one thing, I never got the solution for, that water leak from the working channel. Even though when you insert a scissor or anything, that water comes out and it spills on the camera. And
Madam,
then our
please buy
people,
a silicon washer.
yeah, usually we change for means 1 or 2 uses that will go off. Usually
Madam, I'm
800
using a
rupees of
single washer for last 7 years. Single washer
okay.
for the last 7 years, and I do not have a numbers how many surgeries I performed with that washer.
Yeah,
It cost you around at that time 1,000 bucks. Then
yeah.
it started 1,200. Now it is available in 1,800,
18.
and I have
Huh.
gifted to so many friends.
Okay, then give me
Yeah,
also
it is
one.
available.
Of course, because the
Because
day they see me now, because Dr. Farin, your clothes are not getting wet. Madam, I'm using this washer since so many years. It's available with
which
PB.
company just tell
PB
us?
India, madam, you can
PB.
ask
PB
just
India.
silicon washer, they will
Yeah,
give it
yeah,
to
but
you.
what happens, that single washer हो गया, हम लोग तो imported washer बोल के ही देते हैं. Then we use that thing, but still that water leaks
Only
from that
silicon washer,
side, I think.
good quality one. And I'm telling you, I'm using it 7 years. You can see it, it
Okay.
turned black, but still
Oh,
it's working for me.
oh, nice, nice.
And
Dr.
the
And
other
Prabha,
thing
this
is,
I'll
is as
tell
good
you,
as
Prabha,
foreign.
madam, I
Yeah,
always carry 3 washer with me in my suitcase.
yeah,
Always
yeah.
3 washer, and never had to use these 2. They're still kept like this.
Okay, good thing, good,
and
good.
the other thing is, while inserting the scissor, the assistant has to just close it, and
In spite of that, you
still
get
have to listen.
wet. So better to use a good quality washer. It's a solution for all your
Yes.
solution of your. Otherwise, one can yes definitely insert a scissor, put a hand, put a gauze piece around it, get wet.
Yeah. So many
Use a
circles
washer.
goes off, but
Charge
still sometimes
slightly
it
more to the
happens.
next patient. Buy a washer. Chapter
No,
close.
no, we take the imported washers only by the dealers, but I never happy. I am never
Madam, they
with
make us
any
fool like
imported.
anything. They make us fool like anything.
800 rupees they charge for each washer. I don't know. Means this one I will try with silicone washer with PB
From
India.
10 years back, it was 800 with for that silicon washer. Now they have increased to 1,600 or 800, as sir told.
Whenever I'm
So this
coming to
is
your place,
available
madam,
in.
I'll bring it for you.
Oh
No.
no, no
Yeah.
problem. I will ask her PB India.
This is better than Videshi.
Yes.
Yeah, yeah.
Sir,
Yes.
any tip for the removing corneal polyp and multiple polyp at fundus?
Correct. So, madam, if you're talking about polyps at cornuas, see, even a Lasmar has not described. Lasmar has described classification: upper part, middle part, lower part. He has not talked about the corners of the uterine cavity. If you consider uterus as a triangle, there are 3 corners. One is internal os, another is 2 ostias. Any pathology lying in this corner is difficult to treat. So I had presented many videos. In fact, sir was talking about some award. I got this award for by removing a fundal myomas. So for fundal and corneal myomas, you use an extended lithotomy position, one, so that you can go into the sides as well as the fulcrum is at the internal os. So you, by just taking the instrument of Caesar, you cannot go to the ostias. So you'll have to literally move to on one side with a whole unit. You can move on one side, then you can approach towards the ostium. One. Second, thank you so much for asking about polyp. We have not asked about fibroids because it is very, very challenging to remove the fibroids on the corners. On my YouTube, these videos are available. With this polyp, water jet work as your assistant. So you cut polyp from one areas and then allow you go closer to the polyp. The water jet will retract or reflect your polyp on one side. You will get a space. You can just keep on cutting, come back, take your gun, your instrument again close to the polyp. Again, the water jet will take the polyp on one side. You will get this space and just keep on cutting. Another thing, what you need to understand, that your scissor is 5 or millimeter to 1 centimeter in length. So by seeing your tape, you will not never perforate, madam. It is not that easy. So of course, the thickness is very less into the cornuas, but still, when you are cutting 2 or 3 cuts, maybe blind, then you come back, take again, go close. You will be able to perform this surgery very well. Don't worry.
What about using only grasper and pulling it out?
Very difficult, madam. A grasper works only when you have got a very small tag. This is what we recommend, not to completely detach the polyp from the cavity. Even if you have detached it completely, just stop the inflow so that the cavity becomes standstill. Use a tenaculum, grab the polyp and take it out.
Thank you, Dr. Farendra.
Thank you, Dr.
Things-
Farendra.
Yeah, you can write down these things. Dr. Farendra sir will answer us on.
Madam, I'm just
Yeah.
leaving because I'm in
Thank you.
operation theater. I had to go.
Afterward, if you got. So
If
now
I'm
we
available,
shift
then
to
definitely I'll answer.
next speaker.
Thank you.
Okay.
Thank you.
Yeah, fine. Thank you. Yeah.
Thank you, Dr. Farendra sir,
Thank
for
you, madam.
joining us. And thank you, Prashant sir, for chairing the session. Let's move to our second topic. The chairperson for our second topic is Dr. Nagesh Kumar sir. Nagesh sir is a consultant at Janani Fertility and IVF Center at Tumkur, and he has the special areas of interest are fertility, ultrasonography, and histrolab surgeries. Over to you, Nagesh sir.
Thank you so much, madam. At this juncture, I would like to thank our President, Karnataka State President, OBGYN Society, Dr. Durada sir, and also Dr. Prabha Desai, madam. She's the chairperson of Endoscopy Committee, Karnataka State OBGYN Society. It's my privilege to introduce Dr. Milind Telang, sir. He's a professor of OBGYN, Symbiosis Medical College, Pune, and he's a teacher for teachers, I can call, and he's a senior hysteroscopy surgeon. So we'd love to hear you from sir. You can proceed, sir.
Yeah. Am I audible?
Yes,
Yes,
sir.
sir.
Just 1 minute.
Just go down and share.
Yeah. Share.
Yeah, it is.
Yeah. Okay, fine. Can you see the screen now?
Yes, sir. Yes, sir.
Yeah. Okay.
Yeah.
Fine. At the outset, a big thank you to Dr. Prabha Desai and entire team for having me here. And I've slightly changed the topic which you had given me, and I made it fluid and dynamics in hysteroscopy, because then I think so I may do justice to the topic. Okay. So what I feel is, in education, it is not about learning facts. You have to train your mind to think, and then you can innovate and go ahead and be very safe in surgery. So when we really think about fluid and dynamics in hysteroscopy, one should also know that we are dealing with the uterus. And let's see the anatomy of the uterus. Well, we have in the uterus a cavity, which is a virtual cavity. It is the endometrium, which sheds every month. You have a myometrium, which contracts. There are blood vessels. It requires light to be thrown in, and therefore we require fluid or any distension media. So hysteroscopy therefore took a backseat as compared to laparoscopy, and now you will find that hysteroscopy has gone well ahead, and I feel that hysteroscopy should be done by each and every gynecologist. So the next slide will show you the blood supply, which every one of you is knowing very well. It is very important to us to know that we have the arcuate, radial, basal, and spiral arteries, which are branches from the uterine and ovarian, which supply right from the myometrium to the basal layer to the endometrium. And one has to remember that we transect the bigger vessels, then only fluid absorption is going to take place. At the same time, when we're talking about mean arterial pressure, the arterial absorption, we should also know that the venous pressure in the veins accompanying these arteries is very less, 10 to 15 mmHg, and therefore we can cause passive absorption if you continue to do prolonged surgeries. Then a little bit about the distension media. This is just a revision that we require fluid distension media. Why? Because we want symmetric distension of the uterine cavity. One. Nowadays, we are only there with what you call as normal saline, that is the electrolyte fluid. Very few people or old timers must be using glycine, but everywhere in the world now, glycine is taken a back seat. Why? That is more important for us to know is when you come to know the physical properties of the distension media, one should understand what is osmolality. It is the concentration of osmotically active particle solution, that is the salt content of the solution. And lower the salt content than the normal cells, it is known as hypotonic. And when it is equal to the normal cells, it is known as isotonic. So you will find that glycine, sorbitol have much less osmolarity as compared to plasma. Here you can see 285 is the milliosmoliter per liter is the osmolarity of plasma. And the closest to it is normal saline and ringers. You have also mannitol, and therefore glycine and sorbitol can cause hypotonicity in the fluid, causing hyponatremia, while others can cause just fluid overload because of excess fluid and heart failure, or what you call as overload into the heart. Coming to the next slide, what is the ideal fluid? One should know. These are basic things because one should understand that normal saline is electrolyte rich, but it doesn't cause electrolyte imbalance. We use it with bipolar current. It is isotonic. It is non-toxic. It is hypoallergenic, non-hemolytic. Most important practical point, it is rapidly cleared by the body. Readily available, it is inexpensive as compared to others. If you see glycine, it's an amino acid with a half-life of about 85 minutes. So you will see that normal saline now can be used with bipolar current, plasma current, and also the mechanical tissue retrieval systems. And therefore, one of the most safest distension medium today is normal saline. Coming to the next slide. Sorry. Okay, I don't know what has happened. Okay, right. So coming to the next slide, little bit of distension media and how we send the distension media. We all learned in our basics that we do it by the gravity method. The simplest way of doing it is hanging the bag about 1 to 1.5 meters above the anterior superior spine, and roughly it will deliver a pressure of 70 to 100 mmHg. But you will all appreciate that it all depends upon the tubing. If you're using the urological tubing, the dimension is big, the fluid flow will be big, but as soon as the atmospheric pressure starts decreasing, you will find that the pressure or the fluid flow decreases. So it is driving a cycle down the slope. As soon as the slope ends, you will find that your speed, the momentum decreases. So pressure delivered at the inflow port, remember at the inflow port is always a product of the inner diameter of the tube and the elevation. Here, if the tube dimension remains the same, the elevation is going to decrease, and therefore it can be used for simpler cases, but may not be used for complex or prolonged cases. Similarly, we have the pressure bags, wherein you require an assistant to push with the sphygmomanometer bulb the pressure in the bag. You can use only 1 liter bags. You cannot use the 3 liter bags. So it appears slightly impractical because you have to always tell your assistant to push more fluid so as to gain access into the cavity and to have proper vision. So it is like pushing a car which has stopped. The moment your assistant stops, the fluid stops. And therefore, again, it can be used in small cases, but not routinely. I'll advise you to use in prolonged cases or where you anticipate prolonged surgery or major hysteroscopic surgery. Coming to the ideal and the costliest thing is the automated fluid pumps. Now, these are sensor pumps which senses the resistance to the flow and accordingly sends fluid inside. And therefore, it helps you maintain a proper distension. Fanendra spoke to you that we have to push fluid inside and the fluid has to come out. Yes, all these miniature scopes, if you see, have to work on the principle of continuous flow irrigation. The fluid that goes in has to come out, and therefore maintaining the cavity pressure or the cavity distension is a tricky phenomenon. But what we have learned over a period of time from Stefano Bertocchi and all the other stalwarts is that if you maintain a 200 ml per minute drip rate onto the endomat and an 100 mmHg pressure on the endomat, the eventual pressure in the cavity will be about 70 mmHg or even less. In fact, Stefano Bertocchi went way ahead and put in a cardiac catheter in the cavity to measure actual pressure, and to his surprise, he found that it was between 45 to 50 when you maintain. So this type of pressure can be used for office cases as well as you can use it even in operative cases. Mind you, the distension will be adequate and you will never lose vision. One. Secondly, the most important part of the scope is the outer sheath, which if you see the miniature scopes has pointed out by Fanendra, you can see they have 5 openings on each side, which are smaller. So it requires sometimes active suction to draw out fluid when you're doing operative cases. On the vis-a-vis, if you take the 26 French resectoscope, it has fenestrations or openings all around. So sometimes fluid will come out passively. With 26 French, you tend to dilate, and therefore fluid can come out along the side of the resectoscope also. But if you're using a miniature or a mini resectoscope, then again, you have to have active suction. Now, when you have to have active suction, you have to have an endomat which provides irrigation as well as suction. So these two components are very important when you want to do complex cases which require certain amount of time, and therefore you want proper vision. So why is fluid management necessary? As I told you, we want clear vision. We want the uterus to be distended. We want the pathology to be removed. There should be continuous flow and turnover, removing the blood and the debris. And in operative hysteroscopy, you can have large volumes that can be absorbed. Surprisingly, if you see the literature, severe complications like fluid absorption are said to be only 0.1 to 0.2%, which I totally disagree, because this is that there is no reporting or no one reports his own complications. So that is slightly pitiful, because the next person should learn from our mistakes. Having seen this, we come to what are the predisposing factors which can cause your fluid absorption. And this is very important. There are certain operations which carry a risk. One is a G1, G2 myoma resection, even a G0, which is slightly big. And in G0, you should remember this, whether a G0 myoma is in a nulliparous patient or in a multiparous patient. A 2 centimeter G0 myoma in a nulli is difficult to remove than a G0 2 centimeter myoma in a multi. In a multi, you have around a lot of space, so you can move around and do the surgery very easily. Similarly, when you're doing endometrial resection, it consumes time. Here, you are going to resect not only the endometrium, but 2 mm of the myometrium. You're going to expose vessels within the myometrium, and therefore, these cases are also going to have fluid absorption, and therefore you should have fluid monitoring. Similarly, incomplete septums, because the septum, as initially believed to be fibrotic, is fibromuscular, and as you go towards the base of the septum, you will have blood vessels coming in and causing problems, and therefore you require a monitoring system. Similarly, if you're using glycine, then you require definitely, see, in normal saline also, you can have complications. The complications can occur anywhere with any distension media, but more so in hypotonic, it is a predisposing factor. Premenopausal patients with hypotonic, yes, I will come to why in the next slides. Comorbid patients, the mean arterial pressure is low, and therefore you can have problems. And therefore, you have to be aware of all the factors on the right of the screen. If you're using high intrauterine pressure, you will be in for a mishap. In patients with comorbid conditions, you have low mean arterial pressure, and therefore you have to use less pressure to distend. Surgery time, definitely the BASGE recommends that you have to stop your surgery if you're exceeding 60 minutes. So any hysteroscopic surgery about 20 minutes warrants importance for fluid absorption. Large cavities, adenomyosis, large myomas, large surface area, the endometrial surface area can absorb fluid, and myometrial penetration. So if you do not respect the pseudocapsule in a myoma, then you are asking for trouble. So this is a flow chart which I've created. Gases, we are not CO2, we are not using. So it is only fluid. In operative, we require continuous flow, we require clear vision, and in small procedures, there is no fluid absorption. So fluid absorption will never take place in office hysteroscopies because you will be working within the endometrium, you are working for a smaller amount of time. For fear of pain, you will be using low pressures, and you have made a proper diagnosis prior to doing a patient for office hysteroscopy. All the problems will come in operative when you use for prolonged procedures, when you're using high pressures, and when you're opening up blood vessels. So three things that can be causing a problem are in TCRE, myomectomy, big septums. In monopolar with glycine, you can cause hypoosmolarity, hyponatremia, and neurotoxicity, while in bipolar, you can cause pulmonary edema, CCF. So one should know what is the mean arterial pressure. If you know the mean arterial pressure, it is always wise to talk with your anesthetist regarding the hydration of the patient prior to operation. I always say, plan the surgery in the mind, execute in the OR. You cannot plan your surgery in the OR. What are the problems that one faces in fluid absorption? It's very difficult to collect the fluid and calculate the fluid. Very difficult sometimes to estimate because the bag collapses to know exactly what is the remnant fluid in the bag. Sometimes, and this is seen, and there's a very good study which I will quote later on, is the actual volume in a 3-liter glycine bag that of Baxter's was more than 3 liters actually. So when they label 3 liters, it was more than 3 liters. And sometimes when you move inadvertently and resect a myoma and a blood vessel opens, it will be absolute fast absorption, very difficult to calculate, and suddenly you'll have a collapse which the anesthetist will report. So what are the complications? All types of fluids, as I said, can cause complications. In hypotonic fluid, it is osmotic imbalance between the extra and intracellular fluid. In fact, Megos and Esther clearly said that if there's an intravasation of glycine of 1000 ml, you can have 7 to 10 millimoles per liter drop in the sodium, which can be critical for the patient. You can have hyponatremia and be present in as much as 500 ml deficit. And what does glycine cause? It's an amino acid. It is what you call seen in the liver, that it gets absorbed and is converted into ammonia. Ammonia can cause the blood-brain barrier and causes agitation, vomiting, coma. While it, on the other hand, due to osmosis, it can cause dilutional hyponatremia. It is hypotonic, osmotic imbalance, draws water into the brain cells, causing cerebral edema and seizures. So this can be fatal. On the other hand, if you see normal saline, it can cause pulmonary edema and cardiac failure. Again, with normal saline, the safety limit is up to 2.5 liters in a normal patient. In a comorbid, it is 1.5 liters or sometimes even 1000 ml. In glycine, the maximum limit of absorption in a normal patient is about 1000 ml, but in a patient which is comorbid, it is less than 750. So you have to finish the surgery fast. So again, this is an algorithm which I have devised. Intraposition of hypotonic solution causes accumulation of free water. There is a compensation by osmosis, and free water moves into the extra and intracellular spaces. It prevents the sodium to move outside the brain cells, causing cerebral edema, increase in intracranial pressure, and cerebral herniation, which can be disastrous. What happens in a premenopausal patient? You have estrogen progesterone going on, which inhibits the sodium potassium ATPase pump in the brain, in the blood. And therefore, these patients are 25 times more at a risk with glycine to have cerebral edema when there is excess fluid absorption. And therefore, it becomes imperative for us that we use what is known as a GnRH agonist to decrease the size of the fibroids, or in TCRE to decrease the endometrial thickness. Two things happen with GnRH agonist. One is the vision improves, the time is less required for surgery. You finish surgery fast because the size is reduced, the volume is reduced, and thirdly, it in premenopausal patients, it decreases the estrogen progesterone. Thereby, it doesn't inhibit the sodium potassium pump, and therefore it prevents cerebral edema, which is catastrophic for the patient. So these are the stages of hyponatremia one should never encounter, and from mild to severe can be in less than 5 minutes. So initially it can start with irritability and it can end with hypotension. So in a patient with general anesthesia, you have to advise your anesthetist to be there when you're using glycine, and you have to tell him that you're going to use monopolar current. You have to tell him the time that you will take, and he should keep an eye on the monitor and on the patient while you're doing these cases, because there will be initial hypertension followed by immediate hypotension. So you should not be seeing hypotension, you should be catching hypertension. One. Then if the patient is under spinal, the patient will complain of nausea, vomiting. That will be the most initial sign. And then if there is pulmonary edema, you will have the parotid sign that is positive. But an earlier sign, which I can tell you, is all the anesthetists nowadays close the eyelids. Just open the eyelids and you will see watery eyelids. This is the first sign you can see of fluid being absorbed before. And here, giving Lasix, 10 milligram, 20 milligram will suffice. So whenever you're doing a case of resection, see to it that you catheterize the bladder. Anything under anesthesia, don't catheterize later. So you catheterize the bladder, so you have the entire volume of fluid that is coming out. How do we monitor and why do we monitor? Because we want to prevent complications. Very simple. And to correct any hypoosmolarity before it becomes tragic to the patient. There are two ways to do it. Everyone follows this the manual way. You have a dedicated person who will tell you every 10 minutes as to what is going in and what is coming out. And he should be very alert and he should be deputed only for that work. It is, I'll ask you to that when you put the under drapes, use the PPH drapes which have collection of fluid. Keep those drapes where the fluid can come in. Place a tubing into those drapes and connect it to a suction machine. Just apply suction and the fluid will come into the canister. You do not need big apparatus over there. Keep a big size bucket down. If it spills over, it comes in the bucket. So that is one more. And sometimes if it goes on the floor, you have to then mop the floor and collect the fluid. But in all this, you will have a 10% error. And when you say 10% error, it can be 600 to 1500 ml, depending upon how much you have used. And therefore, it can be tragic to the patient, especially if it is a comorbid patient. On the other hand, what the AHL guidelines have recommended, is that if you're doing a complex surgery for a prolonged time, then you have to use a weight-based management system, not the volume-based management system. Now, what do you understand by this weight-based is all these fluid management systems or machines that are available now, they convert the volume of the fluid, they weigh basically the bottle into from weight, they convert into volume, and the volume is then fed to the machine, and they give you alarms at each spot that you are approaching the deadline. And this has been proved that these weight-based or fluid weight scale is very important, and all these have a weighing scale behind. So when you hang the fluid there, it weighs the bottle, converts it by the software into volume, and then sets an alarm for it. So what are the fallacies? As I just spoke, a 3-liter bag of lysine, even the Baxter's, has a 3.84% what you call overfill. Similarly, the canisters, if they are not calibrated, a 3-liter canister where you collect the fluid can actually be only 2750. What happens with this is with a 3-liter bag, the surgeon is unaware of 365 ml of fluid that is getting absorbed unknowingly. And therefore, you have to have volume-based, rather weight-based systems to provide reliable and reproducible way of measuring fluid deficit. So you should have a dedicated person every 10 minutes after each bag of normal saline. If it is glycine, you have to estimate electrolyte frequently, maybe every 15 minutes during the surgery. One thing one has to do, and that is very important, is never be egoistic and stop the procedure if it's going to take a lot of time. Is there any effect of anesthesia on the fluid absorption? Well, if you're into office or into local anesthesia, least absorption, spinal anesthesia, they have found that the absorption is slightly less than as compared to GA. But this is a study done by Bergeron, and he has found it. But spinal and general anesthesia, I feel that there may not be much of a difference. But under spinal, one thing is for sure, the patient is awake and will tell you certain symptoms immediately. And what is the first symptom of fluid absorption in an awake patient is patient starts coughing. The moment the patient just coughs, that is important for us to alert that something is going wrong with the patient. So how do we prevent this? Well, a thorough pre-operative assessment. Don't consider hysteroscopy to the easiest surgery. Everyone has believed that we just have to put a scope inside the cavity. No, it is not that easy. It's a dynamic cavity. Laparoscopy is much more easier than hysteroscopy. So have a proper imaging, proper 3D. You should plan. You should know what instruments you want to take. You should always tell your team how much time you're going to consume. Always talk to the anesthetist. And here, if you're going to have a surgery of 45 minutes, you're using spinal or GA, ask them not to overhydrate the patient before. The anesthetist always tell us, give 1 liter of fluid prior to surgery. Don't do that. Keep the fluid to minimum prior to surgery. We don't want to overload the system from both the ends. What you can do to prevent, if the myoma size is big, reduces by giving GNS agonist. If you want to decrease the endometrial thickness, use danazol, GNS agonist, or you can use Dynogest, whatever means to decrease the endometrial thickness. It prevents fluid absorption. It can give you good vision. It finishes your surgery faster. Another thing which I use in my daily practice is whenever I'm doing myomas which are more than 2.5 centimeters, maybe even G0, then for the safety of the patient, I will always inject 0.05 international units per ml dilution of vasopressin. That is 5 units in 100 ml, 10 cc at 4 o'clock and 10 cc at 8 o'clock intracervically. And after that injection, wait for 8 to 10 minutes and go in. It causes vasoconstriction. Two things happen. The vascularity decreases and the chances of fluid absorption decrease. While during the intra procedure, one has to be very careful that you don't increase the intrauterine pressure. If you have to, because of debris, then it should be momentarily increasing, but at the same time, you have to increase the suction. Remember the word continuous flow irrigation. Very important. If I'm increasing the pressure, simultaneously, I'll also increase the suction. So whatever debris are there will be cleared in a minute. If there is air bubble, go towards the air bubble with your resectoscope or scope, enter the air bubble, and then press the suction. Everything will come out. Don't try to just suck it out. The fluid, the cavity will collapse. Secondly, don't be egoistic. There's a very, very good paper by Alka Kumar, which clearly states that if you stop surgery for 10 minutes, you're going to prevent a catastrophe. What happens is, if you stop the surgery for 10 minutes and revisit the cavity, though the vision might be hampered, definitely, but intravascular clotting clots the open blood vessel, prevents further absorption of fluid, and therefore you prevent a complication. Mind you, hysteroscopy should be a very, very safe surgery. You cannot have complications in, and I think so Kalyan will highlight more than me on this aspect. And this is a very good paper which shows that pre-op GNH agonist and vasopressin can decrease the fluid absorption as well as the vascularity, and therefore finishing the procedure fast. So everything is about adequate distension, finishing the procedure fast, and having good vision. Three things that lead you to a successful hysteroscopic surgery. And therefore, I believe always, this is, remember, good things always take time, but learn the good things now. It might take time, but you'll prevent a complication. So mind you, safety is a priority. Proper selection of the patient, proper selection of the equipment for that particular patient. Telling your team what you're going to do, that is known as planning of the procedure, and therefore plan it beforehand, talk to the anesthetist, and definitely the surgeon should be skillful. He should have undergone training, especially when you're doing large or bigger cases like the myomas, the big septums, the adhesiolysis, or maybe endometrial resections. So with this, I again thank Dr. Prabha for having me here. And this is how the BSG ESG guideline for fluid management recommendation, how you calculate, how you maintain the drips. Every 10 minutes, you write the fluid input, the output, the fluid balance. Everything has to be maintained properly, and stop the procedure if you're going to go ahead of 60 minutes, or depending upon what you have. If there is what you call deficit of 750 in an elderly comorbid, in glycine, stop. If it is 1500 in an elderly, for normal saline, stop. Don't say, I will finish it in 1 minute and go ahead. You never know when the catastrophe will strike you. Thank you so much. And we all have a School of Hysteroscopy in Symbiosis, where we have our trainings every 3 months for 4 days. This is hands-on training. So anyone and everyone is invited. Thank you, Prabha, for having me here. I think I've done justice to the topic.
Sure, sir. It was really very, very practical talk.
Yeah.
And I'm very happy that you have made all the aspects of fluid management you have covered in such a short time.
Yeah.
Yes, sir.
Yeah.
Any
Thank you,
questions,
sir.
Priscilla?
Thank you, sir. It's such a wonderful talk, and you made it very clear, crystal clear, and also taking precautions, triaging of the patients, the clinical scenarios, and also triaging of the fluid, how to maintain the safety precautions, the discussion with the anesthetist team and also the staff.
Yeah.
And each one has to how each one has to monitor things, and you have made it very simple and crystal clear, sir. Thank you very much, sir. It was a very nice
The
presentation.
main crux is that even if you have done hundreds of cases, each case is different
Yes.
for you, for that particular patient. So take it seriously.
Yes.
Don't take it lightly. I have done 99. This is my 100, and it will be very good. No,
Yes.
it can create a complication.
Yes,
So
sir.
be very careful. That's all.
Yes, sir. Sir, one question from my side, like how do you manage the fluid leak through the cervix?
See, now I'll tell you practically, for last 10 years, I'm not dilating the cervix.
Yes.
So that means I'm not using the 26 French. But if you dilate the cervix and you're finding a leak, then you have to apply tenaculum on both the sides. You put a speculum, apply tenaculum on both the sides, and block the cervical canal from both the sides. It should be only the resectoscope going in. This will happen, especially when you're dilating the cervix for 10 Hagar's 10 number, and then putting in a resectoscope. So, or maybe you're using misoprostol to soften the cervix. I don't use neither misoprostol, neither I dilate. So I have come up with all see and treat phenomenon. See means under vision you enter. So all the complications of dilatation, which is blind entry, is gone. Is gone. So that is one way I look at it. But those still who are having 26 French or 22 French, I would recommend. And if you over distend by mistake, then put the speculum, put tenaculum on both the sides, and then go ahead and finish the surgery.
Thank you, sir.
Yeah.
Thank you, Vin, sir, for such a wonderful talk on fluid management, which is, most of the, the toughest point where all the hysteroscopists struggle, especially the youngsters.
Yeah.
Thank you for taking us
Thank
through
you.
the talk, sir.
Can
And
just
thank you,
one
Nagesh, sir, for chairing the session.
small question, Priscilla.
Yeah.
Just can I ask, sir?
Yeah. Go ahead.
Yeah, just one
Yes,
small.
ma'am.
See, when you use the office hysteroscope, and when you put see office hysteroscope, already we put the pressure of very low, like 80 and 800, and when you keep the Caesar into that operative channel, then still the water flow will decreases. Means fluid flow will decrease.
Now
Whether
you
you
are
will
discussed.
recommend us to increase the pressure and the flow rate?
No. I'll tell you one thing. Now, the trick here is one thing is if you use the Storz scissor or grasper, remember one thing. And if you're using an Indian scissor or a grasper or any other company, when you say 5 French, what do you mean by 5 French? Only the tip, that is the crocodile grasper, the tip or the scissor should be 5 French. The rest of the shaft should be 3 French. This is done only by Storz. Rest, everything, it will be 4 French or 5 French. And therefore, we find difficulty when you put in a Storz sheath, you try to put in an Indian grasper, you will find that the fluid decreases completely. Secondly, when you're using the endomat, it has a sensor. Now, the sensor has already sensed the resistance to the flow. Automatically, it pushes fluid, even though at lower levels, and you'll get a proper. So when I do office hysteroscopy, you will see my operative channel is always having a grasper before I do vaginoscopy. So as I enter the cavity itself, I enter with the grasper in the channel. As soon as I'm in the cavity, I put the grasper out, the fluid comes out properly. Should not be a problem. But provided you have an endomat. Otherwise, if you're having a pressure bag, yes, you have to increase the pressure momentarily to see the cavity. And once you open out the grasper out, you will see that the fluid again comes in properly, because there has to be a difference between the tip of the grasper and the shaft. This is how it has to be made.
Thank you, sir.
Thank you.
Dr. Priscilla.
Thank you, Milind, sir. Now let's move on to our next topic. For the chairperson for our topic is our very own Dr. Shashidhar Reshme, sir. Dr. Shashidhar Reshme, sir, is a consultant gynecologist at Reshme Hospital. He's also the founder president of Gadda Gobigain Society. He's been the executive member of KSOGA, website coordinator of KSOGA, and he has been a faculty at various state and national level conferences. We welcome you, Dr. Shashidhar, sir.
Thank you. Now, can you put it's my pleasure to introduce the last speaker, none other than our president, Dr. Kalyan Barmade. He is currently president of IAGA for the current year 25-26. He is the director of Latur Fertility Center. His contribution to IAGA is very significant. He's been secretary, chairperson of Infertility Amox, chairperson of Public Awareness Committee of FOXI, and managing council of IAGA, Maharashtra ISAR, Amox, and president of Latur OB-GYN Society, president of Latur IMA. He's actively involved in so many organizations, and he's passionate about gynec endoscopy. And he will be talking on the complications of hysteroscopy. All of us presume that compared to laparoscopy, hysteroscopy is an easy thing. But now after today's session, we are having the reverse opinion that hysteroscopy is slightly tougher, though it looks easier compared to laparoscopy. Here I present Dr. Kalyan Barbade, sir. Thank you, sir.
Thank you, sir, for.
Before I forget, I must thank Dr. Prabha for giving me this today's opportunity.
Oh, thank you, sir.
Thank you, sir, for this nice introduction. I thank KSOGA Society and Dr. Prabha Desai for this opportunity. My slides are visible?
Yeah.
Okay. So I'm going to talk on a topic which is very close to my heart. That is what went wrong, how to avoid tips and tricks of hysteroscopic complication. So when I talk about the complications of hysteroscopy, we should know that complications are more common in operative hysteroscopy than diagnostic hysteroscopy. That is around 0.13 to 0.95% when you talk about the operative laparoscopy. The risk increases with adenolysis, endometrial resection, myomectomy, and polypectomy procedures. I'm going to talk on different complication, that is perioperative, about the positioning, about the intraoperative, distension media, which sir has almost covered, post-operative and delayed complications. So when you talk about, I have few cases which has happened in the practice, and this is very interesting case which happened in initial part of my practice. This was a case, 25-year-old lady came with primary infertility since 4 years. Patient posted for hysterolaparoscopy. As you can see, I am not able to see the ostia. The dictum in hysteroscopy is to see both ostia and then only proceed with the procedure. And here I am entering into a pseudo cavity or into myometrium. So this is the most common complication of hysteroscopy which occurs is failed hysteroscope. When hysteroscope cannot be negotiated through the cervical os and procedure may be abandoned, it is called as failure. It can occur in mostly acutely anteverted or acutely retroverted uteruses or cervical stenosis like Asherman syndrome or history of Cox. Cervical stenosis will lead to creation of false passage. The failed hysteroscopy can be because of the cervical stenosis, as I said, acutely anteverted uterus or acutely retroflex uterus, or in cases of nulliparous or postmenopausal cervix, or even nowadays with previous cervical procedures like laser conization, loop electrosurgical excision, cryotherapy, or even trauma to the cervix. Before we go into the details, we should know how the cavity is seen from outside, that is cervix. These are the cervical synechiae. This is the anteverted cervical canal. This is a straight cervical canal, and this is a retroverted cavity. And very important is a lateral deviation, which can occur if there is a ventral fixation or lateral wall fixation of the uterus. So how to manage? In acutely antiflex uterus, place a long bladed open speculum into anterior posterior fornix. It pushes the fundus to the mid position and can facilitate dilatation. Speculum can be removed once hysteroscope is inserted. Another technique which I am going to tell you after retroflex is placing a tinaculum on the posterior lip of the cervix and apply traction. It straightens the cervical canal. As Telang sir has rightly said, with the use of vaginoscopy, we are not able to find this complication a lot, because even if a 2.9 millimeter scope with some misoprostol like drugs put 2 hours or 4 hours prior, the dilatation is automatic and easy, and this complication can be prevented. Bisoprostol 400 milligram either orally or vaginally. In cases where it is not possible, hygroscopic dilators like lamina tent, which is available as Dilapan S in the market, that is to be put 8 to 12 hours prior to the procedure. It dilates mechanically and opens up the cervical canal. And lastly, intracervical injection of vasopressin solution, that is 4 IU in 100 cc of NS, injected at 4 and 8 o'clock position. So you can use mini hysteroscope or hydrodilate. If you are unsuccessful, pass UAG guided lacrimal duct probe or spinal needle or a small hysteroscope. If not possible, you can make a cruciate incision at the site of os and incise through the stroma until the canal is seen, and you can advance the hysteroscope. I'm going to show you a few videos where if there is a stenotic cervical os, you can put the forceps inside the cervical canal, go in, open up, try to remove the mucus or fibrotic bands which are there, and then you can easily remove the mucus or fibrotic band and can open the cavity. Stenotic os like in atropic postmenopausal patient or stenotic os because of the polyps can be removed, and cervical myoma you can see which is protruding out from the anterior of the cervix, and sessile polyp which is occupying the posterior wall of the cervix can cause difficulty. If there is a cervical fibroid, it can be removed by office hysteroscopy, and I have a beautiful video by Dr. Haresh to remove the fibroid by scissors also. In this you can see it is though slightly difficult to maintain the distension. The cervical fibroid is removed through the resectoscope, and then you can negotiate the passage and can do a hysteroscopy later on. The fibroid can be removed by the scissors. You have to open up the pseudocapsule and you go circumferentially on all the sides to remove the fibroid, and this is by OPM technique. You can remove the fibroid and can negotiate the passage. The morcellation of the large myoma which is obstructing the entry can be done by hysteroscopic morcellator, which you can see. I'm putting the hysteroscopic morcellator. A normal saline is a distension medium, and this hysteroscopic morcellator is eating up the tissue, and then we can negotiate very well, and you can see the cavity inside after removing the myoma which was obstructing the entry. Stenotic cervix can be negotiated with the scissors. In this picture, you can see the adhesions which are there, which are removed by scissors, but only in this you have to know whether it's acutely anteverted, retroverted or mid-pose uterus, and with the tactile sensation, you go inside with the closed scissor, open up, and once you get a space, you can do a adhesiolysis to remove all the adhesions, and once you have removed all the adhesions, then you can very well negotiate and enter into the uterine cavity. And lastly, in few cases where stenotic cervix, which is there because of the obstructing fibroid, with the loop, some of the fibroid tissue and the fibrotic tissue can be removed, and entry can be obtained after removal of this fibrotic tissue. There are adhesions where we are discussing at the external os. Sometimes there are adhesions at the internal os like Asherman syndrome, where such adhesions can be removed by the hysteroscope itself, and after adhesiolysis you can enter inside the cavity, and the inner adhesions, that is hysteroscopic adhesions, can be removed with cold scissors or even with a bipolar loop if required in some cases. But those patients where because of the infertility or patient has amenorrhea, it is always better to use a cold scissors for such procedures. The important thing, the idea that changed everything, that internal os is oval and not circular, because Professor Bertocci introduced the vaginoscopic approach, in which after passing the external, the scope is introduced into the cervical canal and slowly moved towards the internal os. The main trick is to avoid possible trauma to the cervix, so that once you touch the fibers, it's going to cause pain to these patients, and you can do an office procedure without any of the trauma. Once you enter inside the vagina, aiming for the deep posterior fornix, you initially place the hysteroscope light lead at 6 o'clock, localize the cervix, and once through the externals, follow the endocervical canal, which is seen as a black hole. Then cervical canal is explored using 30-degree oblique view, and correctly navigating through the cervical canal, the image should place at 6 o'clock position on the screen. Advantage from the arbor vitae longitudinal mucosal ridges, which can be helping in recognizing the cervical canal direction, and then you can correct performance should not require use of valcellum, tenaculum, and you can do a vaginoscopy by this procedure. So that was the failed entry. I'm going to tell you a case which is given to me by Dr. Tanvir, and this is a case came to her for primary infertility with cervical stenosis, which was planned for IVF, unable to pass a IVF ET catheter, referred for hysteroscopy, and here you can visualize that there is something which is hitting the hysteroscope and it is not able to negotiate, and once slowly looking in the posterior wall of the uterus, you can find some instrument which is stuck inside, and you can see at 5 o'clock position, the 7 o'clock position, the instrument which is seen the tip of broken bipolar forceps and which is removed by grasper. Video shows broken tip of needle of bipolar electrode. It was removed using alligator forceps. Tip of electrolyte needle is very fine and thin, can be missed if his absence is not checked by the surgeon or the assistant at the end of the procedure. It is very important for the staff to be alert to see each and every instrument while you are cleaning that something is not missing inside the uterine cavity. Another case is 40-year-old patient returned back from home after 5 days of the surgery done for TCRE with feed drop, no history of any fall, trauma. What must be the cause? This patient in my OPD, you can see she's not able to move her left leg, and this was because of improper positioning of the patient. The nerve injuries, that is, for arm brachial plexus injuries, may result because of the shoulder restraints, but foot drop, which you see in this video, due to pressure on the peroneal nerve by lithotomy stirrups, legs should be adequately padded and supports. Legs should always be lifted. Both legs should be lifted simultaneously and kept together until they are at appropriate height, when they should be abducted gently and placed in the supports. Over abduction may cause damage to even sacroiliac joints. In this picture, you can see this is the peroneal nerve injury which happens here. Saphenous nerve injury happens here, and femoral and obturator nerve injury at sacroiliac joint can happen because of the improper positioning. The prevention is lithotomy modified position, the most ideal position where moderate hip flexion, limited abduction, and external rotation using padded Allen stirrups avoids any kind of trauma to the nerve, joints, and soft tissues. The another case, which is a complication, again, you can see while putting a hysteroscope, I could find that I can see a omentum, and then a laparoscope was put, and you can find that it has perforated. I was very lucky that it has been done with a hysteroscope, so there was no need of seeing towards the bowel. But if it has happened while doing a TCRE or TCRM, then involvement of the surgeon looking for the bowel, and medico-legally you have to be very clear about this procedure. Keeping this patient for observation for delayed complications is must. This was very much a perforation which is common around 14 per 1,000 cases according to the AAGL survey. Perforation is more likely in repeat procedures like Asherman's, and electrical surgical devices cause thermal injuries following perforation and can lead to peritonitis, sepsis, and even death. The tips to avoid creating false passage or perforation is dilate the cervix with slow, steady pressure and stop when the internos opens. Dilators should not be pushed till the fundus. Hydrostatic dilatation with inflow on and outflow off must be preferred. Always insert the hysteroscope under direct vision, keeping the dark circle in the center of the field and slowly advance until the cavity is reached. Morcellators should never be activated outside the uterine cavity, and clear exposure by adequate expansion of the uterine cavity is mandatory while using bipolar resectoscope, hysteroscopic morcellator, mono. So that is very important. And this is a very important picture where it is showing in case of anteverted uterus, this is the incorrect entry which is going inside the posterior wall, and this is the right entry. And in retroverted uterus, you can see the reaching incorrect entry into the anterior wall, and this is the correct entry. So while insertion, you have to be very careful. As per as possible, use vaginoscopy. Those who doesn't have 2.9 mm scope can do dilatation, but otherwise with 2.9 mm scope, there is no need of dilatation. How to manage the perforation? Simple perforation with dilators or scissor, just observe these patients. False passage, if you see muscle fibers, but no ostia, remove the hysteroscope, identify the true cavity, and discontinue further procedure if adequate distension is not possible. Complex perforation by thermal injury, laparoscopic evaluation of bowel injury is must. You identify white patches on serosa, do a laparoscopy or even laparotomy resection anastomosis of bowel. If no injury, close observation for 2 weeks to rule out delayed perforation, and you can do a procedure after 2 to 3 months afterwards. These are certain pictures of the hysteroscopic perforation where you can sometimes leave it alone, can do bipolarize, or even can take stitches. This is another case of during TCRM, that is transcervical resection of myoma, a patient starts bleeding. Hemorrhage is severe bleeding requiring intervention, occurs in 0.5 to 2% of the cases during forceful dilatation, deep ablation and vaporization. There are preoperative measures to reduce amount of blood loss. Prefer vaporizing electrodes for myoma resection. It seals blood vessels as tissue is vaporized. Injection of very dilute vasopressin in 60 ml normal saline for 4 unit into cervix, 2 mm deep at 4 and 8 o'clock positions. Use danazol or GnRH agonist which decreases thickness and vascularity of the endometrium and Schinkel's leiomyoma in prior 1 month. Results in shorter operative time, less blood loss, and less intravasation of the distension medium. If procedure is not completed, do electrocoagulation with wire loop or roller ball, bleeding is controlled, that's fine. If not, abandon the procedure. If procedure is completed, hemostasis via balloon tamponade, insert Foley's catheter, infrared bulb, and observe for 1 hour. If no bleeding, remove half of the saline. Again observe, no bleeding, remove the remainder of saline and Foley's catheter. In some cases, even uterine packing helps. Half-inch roller gauze soak in dilute vasopressin solution of 20 units in 60 ml normal saline. Bleeding is not controlled. You can go for embolization or even bilateral internal ligation. But mind you, many of the times, if you are not injured the major vessels, then it will get controlled by applying a forceps from anterior as well as posterior wall. That is, sponge holder can be applied to both walls together like this, and then you can control this bleeding within 8 to 10 minutes. This is a procedure which we do routinely in such cases where bleeding is there. That is, putting an intrauterine balloon inside the uterine cavity and looking through the hysteroscope and slowly withdrawing the hysteroscope once this balloon is placed at the level where there is a bleeding. Now, another complication is how you manage case of fluid overload during hysteroscopy. Dr. Telang sir has told you everything about this. I'm just going to touch the topic that is non-electrolyte solution that is hypotonic is dangerous, 1.5% glycine sorbitol. Electrolyte solution that is isotonic, normal saline is best. BSG ESG 2018 defines fluid overload as hypotonic solution where fluid deficit is more than 1000 ml in healthy women and more than 750 ml for elderly women or with cardiac and renal comorbidities. Isotonic fluid threshold between 2500 ml in healthy women of reproductive age and 1500 ml for elderly women or with cardiac and renal morbidities. Sir has told you everything. Hypotonic electrolyte-free solution can cause fluid overload if intrauterine pressure is more than 75. Depth of myometrial penetration, large blood vessels are breached. Longer the duration of the surgery and larger the cavity, more absorption causing these complications. Risk factors, premenopausal patients have higher risk of developing neurological complication, cardiovascular and renal disease, and elderly women are less likely to adopt to sudden significant increase in intravascular volume. So 750 is dangerous for them. And these are the symptoms which sir has described. The management is multidisciplinary, strict fluid balance, frequent oxygen saturation, echocardiogram, and then 3% saline can be given for this. The monitoring fluid deficit, you need to have closed system which will allow accurate measurement. Automated systems are better. One person should be dedicatedly seeing every 10 minutes and telling the surgeon fluid deficit is 500, now fluid deficit is 700, and once you are reaching the more than 1.5 liter, you can stop the procedure. BSG 2018 Executive Committee Safety Recommendation says isotonic electrolyte containing distension media such as normal saline with mechanical instrumentation and bipolar electrosurgery because of low risk of hyponatremia and fluid overload. Hypotonic electrolyte-free distension media such as glycine or sorbitol should only be used with monopolar current. CO2 gaseous media should be used for only diagnostic hysteroscopy. Automated pressure systems provide constant intrauterine pressure and accurate fluid deficit surveillance. Advantages in prolonged operative procedures. Measurement of fluid deficit should be done at 10 minutes interval. Local anesthesia with sedation should be considered for performing operative hysteroscopic procedure rather than general anesthesia. We are doing either spinal for these patients or local with sedation is always better. And these are the AAGL practice guidelines 2013. Intracervical injection of 8 ml dilute vasopressin immediately prior to procedure reduces distension media absorption during receptoscopic procedure. Level A evidence, uterine cavity distension pressure should be lowest pressure necessary to distend the uterine cavity and ideally should be maintained below MAP, that is mean arterial pressure. Level A evidence, excessive absorption of hypotonic fluids such as glycine can result in hypotonic hyponatremia. Level B evidence, risk of hypotonic encephalopathy is greater in reproductive age group, that is level B evidence. When compared with electrolyte-free media, saline appears to have safer profile. Level B evidence, excessive absorption of isotonic fluids such as saline even can cause severe complication. That's why continuous and accurate fluid monitoring is mandatory. Level B evidence and risk of systemic absorption varies with the procedure and increases when myometrial contractility is breached like myomectomy or procedure time is prolonged, that is level B evidence. Now another complication which should never happen in anybody's OT because it can cause 50% deaths if proper monitoring is not done. During hysteroscopy, during removal and reinsertion of the resectoscope, sudden fall in SpO2 and patient starts gasping. Air embolism, that is clinically significant air embolism is though rare, but potentially a fatal complication of gas embolism, which can cause sudden fall in oxygen saturation, hypotension, hypercarbia, arrhythmia, tachypnea, and meal-wheel murmur, that is splashing auscultatory sound. The management is immediately abandon the procedure, ventilate the patient with 100% oxygen, give supportive treatment and Durand maneuver, keeping the patient in left lateral position with head low and tender burst position, and in severe cases, central venous catheter insertion or direct needle insertion in right atrium to release the air may be necessary. Preventive measurement is place the patient in dorsal lithotomy and avoid tender burst position because the uterus is above the level of heart and creates a venous vacuum with each relaxation. Pre-op cervical priming must be considered and minimize the cervical trauma. Always keep the os occluded to prevent entry of room air. Keep the large dilator inside till the resectoscope is assembled, and whenever electrolyte to be changed, keep the obturator inside. Avoid repetitive removal and reinsertion of the resectoscope. Best alternative to use MyoSure device that combines both resection and suction simultaneously. Anesthetic should closely monitor end-tidal CO2 and can diagnose air embolism early. Preventive measures: use of GnRH agonist preoperatively, which narrows venous sinuses and prevent this complication. Intracervical injection of vasopressin. Use of vaginoscopic method and avoid using heavy speculums. Flush system with fluid to remove air bubbles. Avoid using gas producing electrosurgical equipment as far as possible. Another complication which can happen is pus in the endometrial cavity, where in this procedure you can see we are doing the dilatation. This is the patient, underwent a surgery 15 days back, came with such pus, and you need to drain such pus whenever you find that there is any pus in the endometrial cavity, because endometritis after hysteroscopic procedure, though rare, it is around 0.01 to 1%. Routine antibiotic prophylaxis is not recommended for postmenopausal, except postmenopausal women requiring IUCD removal. ACOG and SOGC recommend antibiotic prophylaxis for women with history of PID in Indian scenario, which is very much missed. So it's always better to give one shot of antibiotic. Another complication is post-op adhesion formation. Risk of intrauterine adhesions depends upon type of hysteroscopic surgeries. Having the lowest risk is polypectomy and highest risk is Asherman's. Intrauterine adhesions can occur in 37% after monopolar resection of single submucous fibroids, 45% after resection of multiple fibroids. Risk appears to be greater when electrosurgery is used than non-gravity uterus and for blind versus vision-guided removal in the gravity uterus. AGL ESG 2017 guidelines of intrauterine adhesion prevention. Primary prevention is application of adhesion barrier significantly reduces development of intrauterine adhesions in the short term but limited fertility data, that is level A evidence. Secondary prevention, use of IUD, stent or catheter appears to reduce the rate of post-op adhesion reformation. Semi-solid barriers like hyaluronic acid and autocross link hyaluronic gel reduce adhesion reformation. Level A evidence not available in India. Following adhesiolysis, hormone treatment using estrogen without progesterone may reduce recurrence. Level B evidence and role of medicine designated as adjuvants to improve vascular flow to the endometrium has not been established. So they are under research setting. And this is a case of Asherman syndrome which is done. And as surgery, everybody knows how to do about the Asherman syndrome. I'm going to show you at the end of the procedure. You can see the both ostia, and you can do a fundal as well as lateral metroplasty whenever you are doing in a case of, and you can see some of the menstrual blood which is coming out, that is suggestive that actively you are entered at the level of the endometrium has been reached. Once you are done that, you can see this pediatric Foley's catheter, cut the tip, it is going to distend only 3 ml, put inside, take a knot there and cut and put it inside the vagina so that this can be kept for 4 to 5 days at the end of the procedure, and it will prevent the adhesion formation. Now this is very important. My case, septum resection post LSH picture. This is a fundus with narrow escape. Luckily, because this was a complete septum, we kept this patient for elective cesarean section, and you can see a dimpling and scar at the fundus, vertical scar, and this is that you have to do under correction is always better than doing a over correction. And this is a case which has happened in our practice where we did the first hysteroscopy for Asherman. She went to Mumbai for a workshop where second time the hysteroscopic adenolysis was done, achieved both osteocene, but this patient lost to follow-up, came to me again at 24 weeks with hemoperitoneum. Just because some of the amniotic membrane was keeping the baby intact inside the uterine cavity, it was showing that it is not ruptured uterus and hemoperitoneum. So bravely, I put a laparoscope and you can see a band of amniotic membrane with some serosa there at the level of the fundus. And this is again a overcorrection of Asherman syndrome, which has caused this near rupture uterus. And you can see the amniotic membrane sac, which is thick amniotic membrane, is keeping the baby inside the uterine cavity. Otherwise, it's almost rupture uterus. And this patient had Billings stitch, and we had tried to remove the adhesions by hysteroscopy. So sometimes it's always better to tell such patients who have life-saving surgeries during the first cesarean with Billings stitch and amenorrhea for 1 year. We have tried doing this hysteroscopic aerosolysis. It's always better to go for a surrogacy in such cases than always going. And you can see the fetal parts which are there and amniotic membrane was keeping. We did obstetric hysterectomy. Baby was in NICU for 8 days but could not be survived because the weight was 700 grams. So use of newer modalities like hysteroscopic morcellator are better to prevent complication. As you can see in this case, there are multiple fibroids, 3 to 4 fibroids. If I do a surgery with the scissors, it's going to cause a lot of injuries at 3 to 4 points. But this morcellator, which is mechanical, use of saline, it is eating all these fibroids without any trauma to the endometrium. And this patient conceived and underwent an IVF cycle with a healthy baby. So use of newer modalities like hysteroscopic morcellators are always better. And another procedure of removal of bony spicule, this patient came to us with secondary amenorrhea with history of second trimester abortion somewhere because of the IUD. And in taluka level, they did a suction curettage, but some of the bony part was remaining inside the uterine cavity, and these are supposed to be cephalic bones which never came out. And I'm trying to remove these bones with the grasper, and you can see it is causing injury to the endometrium. So it is going to cause again calcific shadows if these bony spicules remain inside the endometrial cavity. So we did with hysteroscopic morcellators, you can see, and it is hysteroscopic morcellator is going to eat out all these tough tissues. And at the end of the surgery, you can see there are hardly any of the tissues which are remaining, and whatever small spicules of the bone which are remaining can be washed up and can be removed with the forceps. So such use of newer instruments like hysteroscopic morcellator, which are safe, effective, efficient, clear, and prevents complication. The advantages, next cycle you can go for IUI, IVF, no energy source is used, so no damage to the endometrium, and intrauterine adhesion formation is almost nil. An extra mile, they can remove RPOCs, removal of the bony spicule, and even you can do a visual DNC in some cases. So before going for a hysteroscopy, I urge everyone to take proper training in hysteroscopic centers and simulator labs. IAG is conducting such courses in different of the places. You log on to www.iagonline.com. You can find many of the centers where you can learn the hysteroscopy, and training on such modules is so important. Now, this is a computer generated image where Vertamed has come up with such modules where it is showing that you are not reaching properly, your fluid distension is not proper. And here we are going inside, performing the diagnostic examination first, then afterwards a resectoscope. This is computer generated. You are doing the procedure and it is telling you your procedure is remaining. You are not in the right direction. There is a bleeder. You use a bipolar resectoscope. So this is the way you should do learning. And IAG has come up with such learning centers with hysteroscopy courses for better learning for all these. And once you are well versed with such learning, then only you should start doing training on real patients so that you can prevent the complications during hysteroscopy. Because in laparoscopy, if there is some complication happens, any colleagues can come and help you. In hysteroscopy, you are alone. You are using only one hand. Second hand is just holding the camera. So you have to be very careful while you are doing a procedure, whenever you are doing a hysteroscopy. Now, this is again use of AI in hysteroscopy. It has revolutionized the way you should start doing the hysteroscopy, learning the hysteroscopy, and preventing the complication. That is very important. In next 3 years, this AI will come in everybody's laptops, in everybody's OTs, where the septum resection, so many cases has been filled to the computer that septum resection is done this way. And you can see on the right side, it is showing 27% procedure is completed. You are going in the right direction. Then here it is showing 55%. And then when you are reaching the ostia, it is showing you now you are 81%. You should be remaining in the center. You should be not going anywhere. Then now it is 89%. It is now giving you warning here. Be careful. You are reaching 94%. So using such tools, and it is now telling you surgery is done, stop it here. So this septum can be done, polyps resection can be done for all these patients with the help of AI, because what is important for us is to prevent complication, betterment of a woman without any complication. If she goes home, that is the win-win situation for patients as well as hysteroscopic surgeons. So take home message, diagnostic and operative hysteroscopy, though safe, overall complication rate is 0.5 to 2%. Pre-op cervical priming with misoprostol is must. Modified lithotomy position and use of padded Allen syrups is most ideal to prevent nerve complication. Always insert the hysteroscope under direct vision, keeping the dark circle in the center of the field, and slowly advance till the cavity is reached. Simple perforation requires observation, while complex perforation with thermal energy, bowel exploration, subsequent repair is mandatory. Please involve a surgeon for medico-legal complication. Balloon tamponade and uterine packing with vasopressin soaked gauze is effective for controlling severe bleeding. Automated fluid measurement system provides constant surveillance on fluid deficit and pressure. Fluid deficit balance must be recorded every 10 minutes and at the end of each fluid bag which is being used. Semi-solid barriers like hyaluronic acid gel and autocross hyaluronic acid gel reduces adhesion reformation. Following adhesolysis, hormone treatment using estrogen, that is high dose estradiol, valerate 2 milligram 3 times a day for 2 to 3 cycles with or without progestin may reduce in recurrent intrauterine adhesions. Sometimes pediatric Foley's catheter for larger septums, larger adhesolysis, or even for grade 3, grade 4 Asherman's is going to prevent your adhesion formation. And lastly, IAG has come up with the Academy of Hysteroscopy. Please go on the website, register there, and there are 2 centers, one in Bangalore. Every monthly training is going on, and one center with Bangalore in Vidyabhat Center, and another center is at Mumbai with Dr. Krishna Kumar. Next year, we are coming with 6 centers, and these training are good. Charges are only 20,000, but you will get certification. You have modules to learn. You have to pass these modules online at home. Then only you are eligible to go in an operation theater and observe the procedures and get hands-on for basic. So please learn hysteroscopy with good centers so that basically you need to avoid the complication. I again thank Team KSOGA and Dr. Prabha for giving me this opportunity to talk on a subject of hysteroscopic complication, which is very close to my heart. Thank you, everybody. And I'm standing for post of Vice President of Foxy next year. Kindly vote for me if you feel I'm eligible. Thank you.
Congratulations, Dr. Barmade.
Shashidhar sir, thank you.
Yeah, it was a wonderful presentation from simple cervical stenosis to spectrum of very advanced life-threatening complication. And you covered the latest is AI in hysteroscopic management and learning part of hysteroscopy. We would like to have you once in Gadag if possible with Prabha. Very nice, sir. Thank you once again. Any questions?
Thank you. Dr.
If
Prabha,
time
please note
permits?
this.
Any questions if time permits?
Definitely, sir. If Kalyan sir is ready to support, we will definitely do, sir.
Yes, and I need somebody to come into managing council of IAG because it is overdue now. Dr. Vidya Bhatt is the only person who is there from KSOGA. Now I require another few vibrant people like Dr. Prabha to stand for the elections. I'll send the voting pads when they come because it is very important for every chapter of state to come ahead into the executive national body, central body, so that they get a proper representation. And we are there to help you to win this election. Thank you.
Thank you, sir.
Thank you.
So if no questions, thank you again.
Sir, everybody has got so much clear thoughts, no questions. Priscilla?
Some IVF experts in Bangalore, no, they prefer to do only hysteroscopy, no need of diagnostic laparoscopy. That's what some people are doing. I'm not convinced.
Sir, what has happened, Dr. Shashidhar sir, that nowadays with the advent of the 3D ultrasound, it is giving you such a clear picture. Also, these people are doing MRI also to know whether there is any peritubal adhesion, small cyst around there. So I believe if they are doing a good 3D ultrasound, there is no need of doing a laparoscopy for every time. Secondly, for hysteroscopy or IVF, you are doing only hysteroscopy is fine. If you are doing a IVF, you need to know what is the size of the tube, whether there are any hydrosulfings. If hydrosulfing, which is more than 2.5 centimeter, then only it is required to remove these hydrosulfings. Otherwise, if AMH is good, there are no peritubal adhesions, no collection, TB-PCR is negative, it is not mandatory to do a laparoscopy. But if you are suspecting on hysteroscopy any evidence of PID, tuberculosis, it is always better to put a laparoscope with hysteroscope.
One thing, sir. Any identifiable lesion in the adnexa through the transvaginal scan? I think such cases we need to evaluate and do histolaparoscopy.
And that's what I'm saying. If you find that on 3D ultrasound, if you find any other pathology which is there, then you need to always remove this prior to going for IVF because you never know. It can be a pyosulfings, it can be hydrosulfings. Even we remove these hydrosulfings prior to IVF. Even we do clipping and drainage of this if there is a clear fluid inside. Or you can do a sulfingectomy also. While you are doing a sulfingectomy, you have to see to it that you are maintaining the blood supply of the ovary properly. So it's a ovary preservating sulfingectomy, which is very required, important procedure if you are going for a IVF procedures.
Yes, sir. Stay near to, while doing sulfingectomy, stay near to the antimesenteric part of the tube. That is one thing.
Yes, sir. Yes, sir.
And sliding sign is one important sign. So it's a bimanual examination doing a transitional scan, and we can look for the movement of the adnexal structures. So yes, that is one point we need to keep.
Nowadays, with the that's what I'm telling you, sir. That all these clinical things are very important. There is no need of doing this 3D ultrasound if you are perfect with this. But with the advent of the ultrasound, that is 3D ultrasound, and now we are urging everyone to do ultrasound yourself and not send this patient to radiologist. Now, with us, only thing which is remaining with us is a hysteroscopy, where surgeons have not entered. So, if everybody, hysteroscope is like a stethoscope of a gynecologist.
Yes.
If you enter inside with a stethoscope, it is always better. So, please invest into hysteroscopy. 2.9 millimeter hysteroscope with the set will cost you around only 3 lakh or 3.5 lakh rupees. You can start doing procedure like diagnostic hysteroscopy first, then slowly go for a polypectomy. Last is fibroid. Before that, start doing adhesiolysis, small adhesions, grade 1, grade 2, then go for a septum. And lastly, you can go for a TCRM, that is transcervical resection. In initial part, take a proper learning, have one mentor in your life, so that in any difficulty, he will be available to you anytime on the phone, because you can be stuck at any point in life, maybe in a laparoscopy or hysteroscopy. So whenever you are learning, have one mentor, that is very important, who is going to be helping hand to you whenever you are stuck in any of the procedure. But mind you, hysteroscopy won't give you time. Air embolism or fluid deficit, it is more than 2 liter. It has to be a multidisciplinary approach. You have to be very careful. So always better to do procedure, a repeat procedure. So for that, Dr. Pharendra was telling about the Lassmann classification. So that is a classification which is going to tell you the scoring system is 1, 2, 3 or mild, moderate or severe, where scoring less than 1 to 4 is single setting. 5 to 7, you have to take a consent that you might require 2 setting operation. And score is more than 7, always go for a laparoscope. Don't try hysteroscope. So scoring depending on what is the involvement of the fibroid, you have to decide. You can't just say, I am a boss, I can do any hysteroscopic procedure. You can't decide that. You have to have a using a Lassmann classification or step W classification, which is said, so that you are there, you are guiding the patient properly. Doing a procedure in 2 settings is not an insult or not something which is not done by the anything. You can do it in 1 or 2 procedures, because safety of patient is more important than your ego. One patient, any death in hysteroscopy, your practice may be ruined. So it's always better to be slow, steady. Our Sai Baba says Shraddha and Saburi. So Shraddha is keep faith in your mentor and God, and Saburi is be patient while you are doing a procedure. Don't feel bad that you are going to do a procedure next time, the half procedure, because you have seen few complications which has happened in our practice. See, I'm doing since 24 years, so patient can get accept. But for a new beginner, it is not very fine to have complication in first year or 2 year of their practice.
And one more thing, sir.
Yes.
Having an ultrasound in operation
Operation
theater,
theater.
like
That we
especially
suggest
when
in cases where there is a gross intrauterine adhesions,
patients.
internose adhesions, is
Yes, sir.
always better to have handy. But usually, if you use misoprostol, you know the 3D anatomy in your brain about the triangular cavity of the uterus is not required, but always is better to have an ultrasound machine whenever you have intrauterine adhesion cases
Severe
like
addition.
Asherman's.
Yes, sir.
Thank you.
Thank you, sir.
Thank you,
Thank you,
Kalyan sir.
Kalyan.
Thank you.
Thank you, sir.
Thank you, Dr. Kalyan
Dr.
sir,
Priscilla, thank you.
and thank you, Dr. Shashidhar Reshme sir, for chairing the session. Thank you, Kalyan sir, for motivating all the gynecologists to also have a hysteroscope. It's not just laparoscopy, but hysteroscopy is also very mandatory for gynecologists. And yes, what you said rightly, this is the area which is exclusive for gynecologists.
And next time, Dr. Prabha,
I would like
request you to
any questions from the
keep a
audience?
CME specifically on office hysteroscopy,
Sure,
so that
sir.
even a gynecologist who is new can do this procedure in the OPD, like copper T removal, small polyp removal. So that can be another one of the topic after 2 to 3 months about CME.
Sure,
Better.
sir.
So there's a question in the chat to enlighten about the placement of patient to avoid foot drop.
I told you, you have to do a flexion, mild abduction, and then external rotation. You're getting it? These are my legs. This is the way you have to. Dr. Farender was telling you about removing the corneal polyps, right? So that is what is very required. And second thing he forgot to tell, that you have to have a stool which has a wheels, so that you can move and go in the corner, opposite corner, so that you can enter. And in this patient, if you do a proper external rotation, you can prevent the complications. Secondly, stirrups, Allen stirrups, which are available in the market, they are soft stirrups, which is not going to cause any injury to the leg. So mostly these injuries can occur at the knee joint, and patient can have foot drop. So peroneal nerve has to be prevented. For that, abduction, external rotation, which is very important with Allen stirrups.
Thank you, sir. Do we have any other questions? So that was a very good interactive session, sir.
Thank you, ma'am.
I would like to take this opportunity to thank our chairpersons, Dr. Prashant sir, Dr. Nagesh sir, and Dr. Shashidhar sir, for sparing your time to chair our sessions and also add your inputs. I would like to take this opportunity to thank our speakers, Dr. Farendra sir, Dr. Milind sir, and Dr. Kalyan sir, for making out time, preparing their presentations, sharing their experiences, and motivating all of us that hysteroscopy is a mandatory part of our life. I also thank our president of KSOGA, Dr. Durgadas sir, and Shobha madam for being with us, encouraging us, and always supporting us. And thank you, Prabha ma'am, for coming up with innovative topics. And every webinar, every month by month, is increasing the people who are attending the webinars. And also, with every month, the topics are becoming more interesting. Thank you, Chairperson, Dr. Prabha ma'am, the Endoscopy Committee Chairperson, for actively taking us all forward. Thank you all the participants for sparing your time and joining us. And hope